Okay, good evening, Facebook audience. I'm Dr. Mark Casanova, the immediate past president of the Dallas County Medical Society and a proud member of the North Texas Medical Society Coalition. I'm joined tonight by two esteemed colleagues, and we're going to share with you some of the latest information that we have available to us regarding COVID-19. A strong emphasis on vaccines, but really open to a lot of the questions that you've shared with us. So again, we appreciate your participation tonight, and we hope that the time together will be informative. I'm going to let my friend, Dr. Dishner, introduce herself.
I'm Dr. Emma Disner. I'm an infectious disease doctor as part of North Texas Infectious Diseases Consultants at Baylor University Medical Center, so Baylor downtown. And I will let Dr. Rogers go.
Yes, I'm Robert Rogers. I'm a pediatric trained allergy immunology specialist. I've been practicing in Fort Worth for over 35 years. It's good to be here.
Well, thanks for joining us, and really kind of wanted to bring together a full spectrum of physicians and experts who have been caring for individuals through the COVID pandemic, and also who've been involved in helping to delve out information, up-to-date information. I will always emphasize that when we do these discussions, that if you yourself have an individual question about your own health, we always encourage you to contact your own physician. The advice and the counsel we're providing to viewers tonight is really kind of focused on the general questions that are proposed. There's always uniqueness to every situation. I think the other acknowledgement we also want to make is, as we've all learned throughout the COVID-19 experience, that information is ever evolving. It's rapidly changing. What we share with you today may very frankly be different a month or 2 months from now as more information is coming down the pipe. With that said, we'll actually start with the first question. Came from one of our colleagues here in the region. And here's the scenario they've provided to us. I've referred a couple of patients for monoclonal antibody infusion. This is an antibody that an individual can receive through the IV that is meant and intended to sort of halt the infection in its tracks. So this is designed for folks who already have a known COVID-19 infection. I understand that it is recommended that they postpone receiving the COVID vaccine for 90 days. However, in one of these patients, the course is a bit more complicated, and here it speaks to that uniqueness of every life situation we have. And they shared the timeline. Exposure on Sunday to an undiagnosed person who tested positive on Monday, which was the next day. So again, classic scenario of asymptomatic COVID-19 transmission. Vaccine number 1 was given on Thursday, also PCR testing the same day. That means they got their first COVID-19 vaccine, which is a win. Congratulations to them, getting that shot in the shoulder. And then also, because they had a known potential exposure, decided to get the PCR test. That's the nasal swab test, sort of our gold standard right now. Unfortunately, come Friday, symptoms of COVID-19 begin. But they were scratching their head saying, well, is this virus or is this the vaccine side effect? Unfortunately, Saturday, they got that confirmatory test, positive for COVID-19. By the way, sometimes the question is asked, does having the COVID vaccine cause you to somehow have a positive PCR test? The answer is no, it does not. Monoclonal antibody on Monday. So here's their question. Should this patient simply get vaccinated for their second shot in 90 days from the infusion, because that's the recommendation, or is it best for him to begin the series all over again? And is that even possible? So I'm going to punt this one to my colleagues. Any takers, Dr. Dishner, Dr. Rogers, have at it.
Well, I think that there are a few things to consider here. And basically the answer is we really don't know the exact right approach to this. What's in this person's favor is that they've had a good dose of the virus itself and generated the full immunologic effect of having the infection. Having the monoclonal antibody infusion certainly would not completely suppress that. And also had a dose of the vaccine, which is a very specific little fragment of the virus, the spike protein that we know we've been talking about for months. So the likelihood is this person has generated a very good immune response now. And I think a 90-day wait to get the second vaccine is perfectly reasonable. In fact, it's not actually, as far as I understand it, a solid recommendation, but the CDC is suggesting that if you've had COVID, that you should wait, you could, I should say could, not should, you could wait 90 days to get the vaccine and allow other people who have not had exposure to the virus to get the vaccine first to get their protection. The 90-day number, I think, is somewhat arbitrary. It is because early in COVID, we were saying you could have protection for at least 90 days after the infection because that was as long as we were able to measure immune responses back in the summer. Now there's pretty good evidence that immunity from natural infection lasts even longer than that. I think that an interesting question that I think is probably not very practically important is, does this person need to get 2 doses because of that 90-day gap between the first and second? My guess would be no, that having that second dose 90 days later is going to be the booster dose that's effective. But I could not point you to any study that would confirm that.
Yeah, that's a great point, Dr. Rogers. And I think it falls into that bucket of more information to come. You know, when we answer these questions, we're going to be candid, honest, and transparent. And if you ask us, what's the scientific data in the literature, we're going to quote the scientific data in the literature, and it says X. Theoretically, could it be Y with a little tincture of time in 90 days? Quite possibly. And we may have that information in the months to come. But, you know, Dr. Rogers, you mentioned a couple of key points about that 90-day window. The reasoning behind it was availability of vaccine and wanting to get as many people that first shot in the shoulder if they haven't had COVID-19, which hopefully they haven't, as soon as possible. So I think that's a good point to make. You know, another question, we mentioned this notion of you can't get a positive test result from having a COVID vaccine. But some folks ask about antibodies, because after all, the whole purpose of the COVID vaccine is to allow your body, prime your body to create protective antibodies. The ability of your body at the first sign of the actual COVID-19 virus to go to work and block it and block its ability to reproduce itself and wreak havoc. So our next question speaks to that a little bit. The question is, should we check for antibodies on patients who've received one of the vaccines, like we check for antibodies in patients who have had COVID, and if so, at what intervals? And this follow-up question is, I think this might be important because we don't know how long immunity lasts from any of the vaccines, do we? I think that second answer is you're right, we don't, but I welcome your thoughts, Dr. Dishner.
So I would say, no, we don't need to check antibodies, partly because not all antibody tests are created equal. Some are not going to be checking the antibody that is going to be created by the vaccine. And then the intervals, I wouldn't check that, that's irrelevant. But the other thing to know is that both Pfizer, Moderna, and I assume Johnson & Johnson are checking to see how long immunity lasts, and as part of their original vaccine studies. So the people who, my office was one of the sites for the Pfizer vaccine, and we continue to, even though now Pfizer is FDA approved, we are continuing to follow those patients to see how they do, check some of their labs, things like that. So yes, we don't know how long exactly immunity will last. However, those things are still going to be looked at, and I don't think getting an unreliable test will help us figure it out faster.
So, Dr. Dishner, I guess I have a follow-up question. Say we do have a patient and we do have concerns about their ability to mount an effective immune response. Maybe their immune system is suppressed for some reason. Do we just order a regular COVID antibody test if we're curious, did the vaccine take? or is there a different antibody test to order?
There is a specific antibody test for the M spike protein, and that would be the one I would check. However, if you are worried about a patient like that, I would do the more traditional tests to see if people can mount a immune response by doing a more traditional vaccine and then checking to see if they have an antibody later for that specific vaccine.
So it sounds like the take-home message is, if you're really looking to determine whether the COVID-19 vaccine, so to speak, can offer an immune response, an antibody response, you need to really check the antibody to that specific spike protein that's part of that vaccine incorporated in that messenger RNA for the for the Moderna or Pfizer vaccine. So great points there. It's just don't check your run-of-the-mill COVID antibody test. Another question. Oh yeah, Dr. Rogers.
Let me just throw in one more thought too. Antibody response is only part of the immune response. And I think many people that have been reading about COVID and immunity also hear us talking about T cell responses in addition to antibody response, which we think of as a B cell response. So much of what we're going to learn over time, and it is only through the passage of time that we can learn this, is to look at real life experience of people that have had vaccination. Because really what we want to do is prevent disease. We want to keep people from getting sick at all, so they not only have it in their body, but could transmit it. That would be the gold, the perfect vaccine. But mainly we also want to prevent severe illness or death. All of the vaccines are very good at preventing severe illness and death. We know that. And so looking over time, depending on how long the pandemic lasts, we're going to be able to look at the real life experience of people who have been immunized and have a very good idea of how long that immunity persists. Not because we've measured antibody levels, but because we've looked at what's happened in their lives.
Great point, Dr. Rogers. And I think it's important to remind ourselves of the ultimate goals and what we're looking for in terms of expectations. You hear these figures thrown out. Well, the Moderna and the Pfizer vaccine are effectively 95% effective. Well, does that mean that there's 95% chance that you won't get infected? Not necessarily. Good, rock solid 95% chance you won't get a serious infection, one that would land you in the hospital. But that whole potential for transmission is still an unknown, as is the length of time that the immunity will last. Let's talk a little bit, change gears slightly, but trust me, we'll come back to vaccines. Next question was posed, and certainly those of us who have seen patients in the hospital setting and even had friends or others who have been affected by COVID, one of the very disheartening, scary phenomena that can occur with this are what we in medicine call thromboembolic events. These are basically blood clot events. And these can occur in the heart, causing a heart attack, in the brain causing a stroke, or even in the limbs causing the loss of limbs. And what our colleague asked is, are there any thoughts on post-COVID anticoagulation? And what his observation is, yes, we've all recognized these very tragic blood clot events, thromboembolic events, for folks who are critically ill in the hospital, but he's even seen some in the outpatient setting. And a bit of time after the acute infection, doesn't seem to be enough data, he writes, to warrant aggressive intervention, but I'm already telling many post-COVID patients to take an 81 milligram aspirin from now until the day that we know more. I'd love Dr. Dishner's perspective on this. As an internist by primary training, I think that seems reasonable. I think a judicious, middle-of-the-road approach, provided that you confer with your physician and you don't have an aspirin allergy, is reasonable to consider. More aggressive blood thinners or anticoagulants, you really need to weigh the risk and the benefits. Dr. Dishner, any thoughts on that?
I would agree. I reviewed the CDC data on this just before this, just to refresh my memory about it. And there isn't enough data to point either way. I do think that an 81 milligram aspirin, barring some other reason you can't take aspirin, is a reasonable compromise. However, there's no real right or wrong answer in that way.
Next on the list, we actually will reiterate, but Dr. Rogers already alluded to it earlier. How soon can a patient get COVID vaccine after recovery from COVID infection? Theoretically, shortly thereafter. The recommendation is to wait 90 days, but it's really to help our fellow man and woman, right? Help all of us get those shots in arms of individuals who are at greater risk and at the risk of very significant sequelae. Just as a reminder, those are individuals who are over 65 and certainly over 75. The risk goes disproportionately higher once we cross that 75 or 75th year birthday. And if we have certain medical conditions, diabetes, heart disease, lung disease, chronic kidney problems, we refer to as end-stage renal disease, and for those who are obese. So those are the folks that we're still trying to churn through because there's a lot of us out there getting that 1B population vaccine. Another question is asked, if multiple family members tested positive for COVID, when should we count the day to start isolation for a newly positive COVID-19 member? So do we start the isolation on Monday because, dad got tested positive? Or do we start the isolation for our 18-year-old Johnny on Friday? Doctors Rogers or Dishner, I'm going to punt that one to y'all.
I can take that one. So I wasn't sure I fully understood the question. So what I would say is typically is the first, so if my husband is positive on Monday and then I start feeling sick on Friday, I would count time of isolation from the first day that I have symptoms. And I think that's how I interpreted the question.
Yeah, that's the question, and it's actually regrettably a fairly common question. We have folks who have multiple family members, in some instances even multi-generational households, and whether it's an issue of when can you safely return to work, when can Johnny go back to school, should be that time frame for you yourself in terms of testing positive, of coming down with symptoms.
Right. So you think about the purpose for the isolation. You're thinking that you're trying to protect other people from becoming infected from you, right? So the timing would start when you think you've become infected, right? Not that you had exposure 4 or 5 or 6 days prior or 2 weeks prior for a family member. Because again, once you start becoming ill, you think, this is what we've learned, that it takes about 10 days to get to the point where you don't have enough virus shedding that you would be a risk to other people.
No, that's a great point. One question that was asked is, what is the evidence that the messenger RNA spike protein of current COVID vaccine will not alter an individual's DNA? That's something that we've heard before, and I think you see chatter about on Facebook. There's effectively no potential for individuals to receive genetic modifications or engineering, as much as some of us might like to grow a few extra inches at the age of 47. It's just not going to happen. Just a reminder how the messenger RNA works itself. The messenger RNA is simply a blueprint. It's kind of like a sewing pattern, if you will. It's encased in these little mice cells, so these little small microscopic balls, if you will, that land on or that are injected into your shoulder and incorporated into your cells. In a normal circumstance, when our body produces messenger RNA, a blueprint to turn around and produce a protein, whatever that protein may be, it modifies it or prints it out in the nucleus, and then it goes into the cell outside of the nucleus. It's in the nucleus that our DNA lives, that our blueprint lives, if you will. So in the cell, it lands on a structure called a ribosome. And the ribosome is simply a factory. It takes a blueprint, or it's a sewing machine, if you will, takes a blueprint and creates your sweater. Simple as that. In this case, we're not even touching the nucleus at all. We're not touching DNA at all. We're just injecting these little mice cells, these microscopic little spheres that have the blueprint ready to go. Cells take it in, send it to the sewing machine, otherwise known as a ribosome, and voila, we produce a spike protein that our cells then kick out and recognize and say, hey, wait a minute, this is something foreign. I'm going to begin to mount what's called an immune response. We talk about antibodies, but Dr. Rogers earlier also mentioned that antibodies are just a piece of it. It's T cell, it's memory, it's a whole cascade of events that help our body recognize these foreign proteins in the future. Now, speaking of that process and the body's response and something called innate immunity, Dr. Rogers, one of the questions was, what is proven to increase innate immunity? Now, you may interpret that question one way. When I read it, my thought was, are there things that we can help to buttress our own immune response? That was my interpretation. You may have others, but I wonder what your thoughts are.
Yeah, that's the way I interpreted it too. There have been so many suggestions of things that we could do to make our immune system stronger to be able to fight off our COVID or any other infection more effectively. And I don't know if this is good news or bad news. I consider it to be good news. Humans have evolved a very effective immune system. And if you are a generally healthy person, if you eat a healthy diet, you have a good, strong immune system. And there is precious little evidence that any supplement can make your immune system stronger. This idea of an innate immune response basically is what in immunology we think of as a non-specific response. That is, it's not specific to a particular virus or bacteria shape, protein structure, but it's really just your first line of defense against infection. And we basically have what we have for that. And there is not much evidence that vitamins or other supplements will make a significant difference on the immune response.
Thanks for that. Dr. Dishner, one question came in, and I think one of the things that we've realized and we've faced as physicians and healthcare providers in the COVID pandemic has been this basically the lack of effective therapeutics, right? And in any normal human crisis, that causes us to get aggressive, right? And in some instances, even desperate. We're searching for the Holy Grail. We're searching, in some instances, for anything that even helps. Period. We'll take a smidge as opposed to nothing. And so, in that vein, one of the more recent medications that has been purported to potentially help is a medication I personally, as an internist, haven't prescribed. I think ever, and if I did, maybe once. Ivermectin. What do you know about that, or what can you tell us about this? I've read about it, I've heard about it, I've had a couple of colleagues ask me, Mark, should I be delving out Ivermectin, despite the fact that I don't even know how to spell it?
So ivermectin is an antiparasitic. In my line of work, it's most commonly given to treat parasitic infections, specifically in transplant patients. So ivermectin, in regards to coronavirus, the in vitro studies that show that ivermectin could help prevent the spike protein from incorporating into the cell of the coronavirus, it seems that you would need to have a concentration of ivermectin 100 times what the normal dosing of ivermectin is. And so why some countries have approved this and versus US not, is part of it is that to get to those types of concentrations within the cells would be very difficult, and you would have more side effects associated with ivermectin. And it's frustrating for everyone to not have a go-to treatment, but I always kind of fall back on the first part of our job is do no harm. And so I think of it as, not everything is risk-free. And to me, it's going back to do no harm. And yeah.
Now, I think that's a great point, Dr. Dishner, and something that we mustn't lose sight of in those times where we feel desperate and we desire there to be something. We still need to be careful. Dr. Rogers.
Yeah, I think another important comment for, especially for physicians and our colleagues, is that we all recognize that COVID, the illness, has an incredibly broad spectrum from asymptomatic to dying. Any individual physician who has a hypothesis about a treatment that might be effective might see 20 or 30 or 50 patients and use that treatment and think they're doing a great job because those patients didn't get sick, but they weren't going to get sick anyway. I mean, you don't know. The only way you can answer a question like that, particularly in a disease like this that has such a wide spectrum of symptoms, is to do what's called a controlled study, where you have some patients that are taking the treatment and other patients are taking placebo, and you compare their outcomes and you see if there is a benefit. We've seen this through this course of the pandemic. Remember when there was so much excitement about hydroxychloroquine and then zinc and vitamin D, and the ones that have actually gone through some controlled studies, enthusiasm wanes. So I think we're just really in a position of waiting for a really well-designed controlled study on ivermectin to be able to make a logical recommendation about whether to use it.
Yeah, great point. The next question, I think, again, I suspect this falls into the bucket of more to come, and Dr. Rogers alluded to it. How long is a vaccine good for, and will I need a booster at some point? And I think what they were really asking is, how long does the protection and immunity last from these vaccines? And we simply don't know. I think my philosophy in many aspects of life is to I think we're better served by assuming that let's say you will need a booster, and if it proves that you don't, great, that's a win. So a decent chance we might need a booster, more to come. What we also don't know is we're about to have another vaccine likely coming down the pike, the Johnson & Johnson vaccine. How will that behave? So it's going to be a little bit of a mixed bag when we talk about, will I need a booster? Well, is it a booster for the Johnson & Johnson? Is it a booster for the Moderna or Pfizer? So more to come. Here's a very common question, regrettably, and this has impacted so many individuals as of late, whether it's been weather related or supply related. The weather delayed me getting my second shot last week. What should I do? Great article in Science came out a couple of weeks ago about this. And again, goes back to this notion of, we're going to share with you the candid information and the direct information we have from studies. Studies are designed for a 21-day window for Pfizer, 28-day window for Moderna. Where there are a small subset of individuals that went a little bit longer in the Moderna in particular, out to, I believe, 45 days. Yes, it turns out there were. So if you ask us what our theoretical scientific answer is, and I would certainly turn to Dr. Rogers as an immunology expert and Dr. Dishner as an infectious disease expert, I think many of us would say it should be okay within reason. Now, going out a year is probably too long, but if you miss it by a week, a 2 week, probably not the end of the world. Is that supported in a scientific study? Not yet. Doctors Dishner and Rogers, what are your thoughts on that?
Well, I'll say we're going to get a lot of real world evidence on that fairly quickly because not every country is taking the same strategy for vaccine distribution. So in Great Britain, they've made the decision to delay second dose to try to get more doses, initial doses to more people. In our country, we're going to be staying pretty clearly tied to the study doses of 21 or 28 days for those two vaccines. So we're going to have that information. And it's not going to take a long time to get it because we're immunizing millions and millions of people. The data is going to be coming in strongly.
Thanks. Speaking of the Johnson & Johnson vaccine that's, again, likely to come down the pike, two questions on that one. Here's the first one. If the new vaccine from Johnson & Johnson will only require one shot, Can I just get one shot of the other current vaccines, Pfizer or Moderna? Uh, Dr. Dishner, before we move on to the second, do you want to take that one and why the difference? And
Well, so the Johnson & Johnson vaccine is a more traditional vaccine, and the Moderna and Pfizer vaccines are the mRNA mechanism. And so I would say there's probably at least some effectiveness once you get that first vaccine of Pfizer and Moderna, but not, but the way it has been studied is to get to that 95% effectiveness to prevent severe disease, you have to get the second one for both Pfizer and Moderna.
kind of reminds me of my old Beetle. There's a little bit of priming of the pump that's necessary, right? And the Moderna and the Pfizer vaccine, this messenger RNA, requires a little bit of priming of the pump. You need to introduce it, and then you drive it home with that second vaccine. And Johnson & Johnson, and I believe there may be one other candidate that's in the pipeline that is a single shot vaccine, seem to do just work by a different mechanism, not messenger RNA based, but have the ability to affect a more secured and stable immunity with just one shot. You know, sort of the pump is essentially primed by the mechanism of the vaccine delivery. Now, a follow-up question, another Johnson & Johnson question, and I think this is an important one, and I hope you've been listening throughout, but share this answer with your friends, hopefully. Why is a Johnson & Johnson vaccine so much less effective? How can I make sure to avoid getting that one? So here's a couple of thoughts and perspectives. The three of us on this visit tonight would all say, you know, we harp every year about the flu vaccine. Get your flu vaccine. It's super duper important. It's protective and hands down saves lives. If you ask me, Dr. Casanova, how effective is a good flu vaccine? Meaning we forecasted it correctly, better than the weather forecast on every average evening, and we knocked it out of the park. It's not that great. It is sure as heck nowhere near 95%, much less I believe that Johnson & Johnson is in the 83 to 85% range, if I'm not mistaken. Of what? Of protecting against severe illness and certainly death. Your average run-of-the-mill annual flu vaccine, which we consider to be good and effective, and please do get it, by the way, every year, it can vary from 30 to 50% effective. Still very protective against severe illness, but that doesn't mean you can't get the flu. So our counsel and our perspective is, listen, the Johnson & Johnson is a rock star as well. It's maybe singing soft rock, but it's still a rock star. So at the end of the day, our mission, our goal is to get shots and shoulders so that we can return to normalcy. Okay, so that all of the ways that COVID-19 has impacted our lives, our quality of lives, and namely the impact on our simple longevity and our health and welfare can be brought to a halt. The only way we achieve that is by getting shots and shoulders, whether it's Moderna, Pfizer, or a very effective Johnson & Johnson. Dr. Rogers or Dishner, any other thoughts on what is a soft rock star, but still a rock star?
I would certainly agree. Anybody should get the first vaccine available. I mean, that's really just the message. Get the first vaccine available. If we learn next year that maybe one of the vaccines needs a booster and another one doesn't, we can deal with that. But I really hate hearing people say, oh, I'm going to wait and get a specific vaccine. And I hear it both ways, and I'm sure you both have too. Some people say, oh, I don't want that new mRNA vaccine. I want one of the more traditional ones. I can understand the anxiety, but I'll tell you, there's a part of me that thinks I wish I could have just had the Johnson & Johnson, because I've had a lot of colleagues and friends and patients that had pretty significant reactions to that second dose of the vaccine, which, by the way, is good news. It means you're having a really good immune response. But it is something to get through, the discomfort for sure.
I would just add, I kind of feel bad for the Johnson & Johnson vaccine because 65% is very good. 95% is kind of like being, you know, the silver medalist against Michael Phelps. Like there's just so, in a way, it's very hard to compete with that 95% number. But 65% is great. And the other pro that with the Johnson & Johnson vaccine is that it can be a lot more accessible to people because of it doesn't require the same kind of refrigeration and things like that because of the delicacy of mRNA versus the more true. So yeah.
So take home message is when you can get it, get it. And get your friends to get it, get your loved ones to get it, and let's get past this. Here's something that is on all of our minds. And I, you know, every time I hear it roll across the evening news or see an email message come across, it catches my attention. How worried do I need to be about all these virus variants I'm reading about? Will the vaccine protect me from all of these? Fantastic question. So far, the initial data, at least from the UK variant, are the Pfizer and Moderna look to be effective. But every day we turn around, there's new variants. Now, it loses some degree of effectiveness. But as Dr. Dishner was pointing out, it's so darn effective, globally speaking, that we're likely not going to lose much. But I also understand that Pfizer and Moderna, as we speak, are in essence backfilling, if you will, or incorporating some of these new specific spike proteins for these variants into their new current batches. So going back to that earlier question about, will I need to get a booster? It might be a possibility that depending on the behavior pattern, as Dr. Rogers was mentioning, because this is a work in progress, it is quite literally a study, an observation in progress, that if it proves that one of these variants are more effectively bypassing the protection of the vaccine, then yes, we can incorporate that spike protein and perform backup boosters, if you will. Doctors Dishner or Rogers, any other points about that?
I would say the other point about variants just in general is that the sooner we can get everyone vaccinated and we can decrease the amount of virus circulating in the community, the less variants we will have, the less opportunities that the virus will have to mutate. So it's our best shot is to get shots in arms and people to get vaccinated for both yourself, your family, and humankind.
So I'm hearing a theme from the two of y'all. Shots and shoulders, shots and shoulders, shots and shoulders. Yeah, go ahead, Roger.
I think, and maybe we're going to get into this more, but it's not just shots, right? I mean, we still want to do our protective measures, which I know everyone is absolutely sick of hearing about, but wearing a mask and keeping your distance, not being unmasked inside with people that are not in your pod, which is the way I think about it. The riskiest thing any of us can do is to be in an enclosed space with people that we are not usually in contact with and not wearing a mask. That is your highest risk of getting the infection. So we still want to keep that under control. Our numbers, everybody is thrilled, right? Our numbers have dropped precipitously. The number of new cases, hospitalizations are going down. Finally, deaths are going down as the lagging indicator. We're doing a great job right now. We have not had Christmas since Christmas. We haven't had a really big reason for people to get together. We had the deep freeze keeping people from going to restaurants last week. I mean, there are a lot of good things going right now. And again, it all feeds back to this risk of variants. Viruses mutate all the time. Most of the time when they mutate to a form that they can't keep reproducing. But they occasionally make a mistake that is good for the virus to survive. So the fewer people that have the disease and the fewer mistakes that could be favorable that can be made is going to help. Again, it helps the humanity in the long run. So we have to hang in there with those protective measures for just a bit longer until we have our immunization rates higher.
Well, Dr. Rogers, as as I've learned that you have an uncanny ability to do in this last year and several months working with you, you have an uncanny ability of reading minds, because that's exactly the last question I was going to close us on. And I'm so glad that you brought it up, because um, one of the challenges as physicians is to be an effective teacher, right? To fully explain why we harp on folks and say, wear your mask or get a shot in your arm. Okay, those are simple words, and you may say, fine, I'll do it. But you also deserve to understand the full spectrum of that. What's everything behind that? Wear your mask, watch your distance, wash your hands, and now get a shot in your arm. And it actually was asked by one of the folks who put in a question, and here's how they phrased it, and Dr. Rogers touched on it eloquently himself. And this is a legitimate question, by the way. If I continue wearing a mask and keep reasonable distance from people, what activities can I start doing after I'm vaccinated? If I have to keep isolating myself from everyone, why are we vaccinating people, right? What's the end game? And, we would love it for it to be a situation or scenario where you get that shot in your arm, and oh, by the way, full immunity, that 95% gold medal rock star level, still takes weeks to occur, 4 to 6 weeks, ballpark range after that second vaccine. Great for you. You're protected. But we still don't know if you have the ability to unknowingly acquire the virus and then pass it to another individual. So part of this is for you, and we care about you. You're our family members, you're our loved ones. Also, it's for the rest of our family members and loved ones and friends around us. So we need to protect individuals from getting the vaccine and having harm done to them. And then we need to halt the transmission of the vaccine. And that's going to require getting to that critical mass, otherwise known as herd immunity. When enough of us have that protection, and that little virus booger just can't land on any of us, and it's bouncing around and it can't get a foothold, this will come to a close. It'll still smolder like embers, but effectively the world we're living in will be able to transition back to remnants that we remember from only a year and several months ago. So it is an ask of patience. It is an ask of endurance, as we all collectively get to the point that we can begin to get back in a staged fashion to those activities that don't require necessarily a mask and 6 feet distances. And so that when we see each other, we can re-engage in that big old hug. I'm going to welcome Dr. Dishner and Rogers to close us out with any other comments tonight that we want to share with our viewers.
Well, I'll ask my own question related to that specific one, which is if I and my closest friends who are also old enough to qualify for the vaccine and have received it, and all of us are vaccinated, do you have any hesitation with that group of people meeting for dinner or going to a restaurant on their own, being close to each other?
We'll see, but we'll see where Dr. Dishner and I fall on this. A close with a challenge. Are we on the same wavelength? Here's what I would say. I'm more comfortable if you threw out the scenario, we're going to gather in our homes, and it's just this little nucleus of individuals. Another classic scenario is a family unit. Everybody in our house, in your house, everybody's been vaccinated, and we're also still being careful, still being mindful when we're out and about and around others, still wearing a mask. Yeah, I feel a whole lot more comfortable post vaccination of that group, of that cadre. Public still makes me skittish. Still support your restaurants. Get the takeout. That's my bias. That's where I'm at right now. Now, I will say, but to follow up on what I said earlier, in tincture of time, I am going to be comfortable in that restaurant ultimately and eventually. I just need to see more folks get vaccinated. But yeah, I think that circle of vaccinated friends and good behaviors, mitigation behaviors outside of that circle of friends, yeah, I think it's reasonable at this point.
I would agree. Actually, I think that my world is very small right now outside of work, and I hope to start opening it up as my family and friends are able to get vaccinated, and those would be the people who I start opening our home to or going to their home. Yeah, support your restaurants, eat local. But I do think that being in an enclosed space with complete strangers is still makes me skittish also.
Thank you. I think we're all in agreement.
And
We're
Dr.
gonna
Rogers,
lengthen
as
the
you
range
always
just only
do,
a little bit.
yeah, as you always do, you manage to end us in some hopefulness and positivity of something to look forward to, right? And I appreciate you for that magic ability of yours to always find the positive, and we do need to find the positive right now. And we hope that if you've watched this with us tonight, that you found some positive information in it. Um, sometimes positive information is measured by candid truth, and the reality isn't always great information. It's not the news we always want, but it is what it is, and we can work with this and we can get through this together. So proud of North Texas and your efforts, and we remain here as a North